Afternoon or morning, depending on your time zone. Welcome to our webinar, Understanding the Final Payment Rules, Comprehensive Care for Joint Replacement. I'm Kurt Harden, President and Chief Operating Officer for MedBen Analytics. We provide analytics solutions for hospitals, health systems, and provider organizations working in the bundled payments environment. We turn claim data into actionable insights for success. Today I'm joined by Kimberly Hartsfield, Vice President of GE Healthcare Camden Group, to review the final rules for the Comprehensive Care for Joint Replacement, CJR, as it is called. We'll also discuss some practical considerations for managing the new mandatory bundle, and we'll look at some reporting needs as well. The agenda for today will be as follows. First, an overview of the final rule. Next, we'll highlight the changes from the proposed rule. We'll discuss considerations for implementing the CJR model, and then we'll review some needs as you move down the CJR path. Our planned time for this webinar is 1 hour. We'll respect your time and do everything we can to stay within that time frame, including your questions. While your phones are muted to optimize the sound quality of this webinar, you're invited to simply ask questions using the question feature on the GoToWebinar sidebar. You just type your question into the question section at any time during the webinar. You hit the return key, and we'll be able to see your question. I'll ask the question, and either Kimberly or myself will answer. At the end of the prepared comments, we'll walk through those questions as part of that question and answer session. Following this presentation, a copy of the PowerPoint will be emailed to you as a participant in this webinar. The final page contains our contact information for additional follow-up. The email, I should add, is going to be coming from Sally Wood in our offices, so you can look for Sally's email following the conference call. I'm now going to have Kimberly Hartsfield take over for the next part of the presentation to review the final CJR rules. As I mentioned, Kimberly is Vice President for GE Healthcare Camden Group. She's been working with bundled payments for 5 years, first with Arkansas Blue Cross and Blue Shield, and since 2014 with the Camden Group as a member of their bundled payments team. Kimberly speaks frequently on bundled payments for national audiences. She was instrumental in the development of our analytics tool, and we're delighted to have her join us today. Kimberly, I'm going to give you the presentation screen here and let you take over.
Show my screen. Okay. Can you all see my screen?
I can see it, Kimberly.
Awesome. Kurt, thanks so much for a great introduction, and I appreciate you all having me join today. So I wanted to talk a little bit about the transition to value-based reimbursement as we think in the context of CJR. And I was fortunate enough to hear Patrick Conway from CMMI speak a couple of weeks ago. CMS has been very intent on their goals of achieving payment transformation from fee-for-service to fee-for-value. And their goal was to have 30% of those payments tied to a value-based reimbursement methodology by the end of 2016 and 50% by 2018. What we heard from Patrick that I thought was so interesting was that they are already at 30% and have achieved that goal and are well on their way to 50%. And one of the other things that I think he said that was really, really key for everyone that's facing the CJR mandate, and also for those that aren't, is that the CMS of old, that people knew and anticipated that there would be slow pilot initiatives in place for 5 years and that there wouldn't be changes, that methodology is gone. And really they're looking at the data every single month, and they're going to make alterations to the program based on the feedback that they're getting from the participants. And that's very much what we saw in the rollout of CJR from the proposed rule to the final rule. They really listened to the participants, and they made changes that made the program more fair for the folks that are facing risk. So if you look at bundles in the context of different methodologies to really bend the trend and bend the cost curve. This is a study from the New England Journal from 2009. And what it showed was that among all the methodologies that are being considered for actually decreasing the cost of healthcare, bundles showed the most promise. And what we know now that we're several years into this is that indeed this is true. It's well documented in the literature that bundles do lower the cost of healthcare. And so it makes perfect sense that CMS is jumping on the bandwagon. They really led these initiatives to put bundled payment programs in place in both a voluntary and now in a mandatory framework. So BPCI kind of led and was the forefront of bundles for CMS, and the program has been in place since 2012. They already have results, and so what are some of the impacts that we've seen from BPCI that they're anticipating seeing as a part of CJR? Well, readmissions have been significantly reduced. They're saving lives, they're improving transitions of care, and they're keeping people out of the hospital. Average length of stay has significantly decreased for the bundles that are in place as well. There's been a huge reduction in discharge to both skilled nursing as well as inpatient rehab. People are being incentivized by these bundles to look beyond their four walls and really focus on that post-acute arena. And there's been a significant increase in home health utilization. So for DRGs 469 and 470, which are what we're talking about today in relation to the CJR initiative, national practice or national best practices indicate that with total joint patients, somewhere north of 80% of those folks should be able to go directly home. And the practice patterns across the country really vary. And so it's eliminating that variation that may be unfounded that CMS is really looking to do. So when you think about the CJR initiative, it's based on BPCI Model 2. It is a mandatory program, as I said, 90-day retrospective episode of care, and is for MSDRGs 469 and 470, that's joint replacement with and without complications. Interestingly enough, it does include partial hip replacements, it does include fractures, and it does include total ankle replacements, which may be something that you weren't thinking of. As part of the program, it's the inpatient stay, including both the facility and professional fees, so all Part A and Part B payments. And then that 90 days of post-acute care, so all of the post-acute care, and then related readmissions for within that 90-day period. You may ask yourself, what is CMS considering a related readmission in this program? For total joint replacement, basically anything that is a medical readmission. So if you get readmitted for diabetes or sepsis, they're going to consider that a related readmission. If you have to have a cabbage, on the other hand, that's probably not considered a related readmission. And one of the other things that has kind of been a surprise to some of the participants in BPCI is that behavioral health readmissions are also considered related. The program is starting April 1st. This is one of the changes that CMS put in place based on the feedback from the mandated participants. Initially, the program was to begin January 1st of 2016, but they decided to give folks a bit more time to prepare for the program. It is a mandatory 5-year program, and as well to allow people to prepare, there is no downside risk in year 1. And we'll talk about the quality metrics that are required in a little more detail in a second, but there are quality measures and mandatory submissions that providers have to make as a part of this program, which is also a difference from BPCI because that quality payment was voluntary. So when you think about the financial implications of the CJR program, I think it's really important for, if you're facing the mandate, there are average episode payment costs that CMS publishes on a regional basis. So if you take the number of cases that you have and you multiply the average episode cost and take 20% of that amount, that's the risk that your organization would be facing from a down or upside perspective in years 4 and 5 of the program. They are scaling in the risk, but people need to be aware of the risk that this program poses for their organizations and the benefit that can be earned as part of a successful participation in the program. So CMS is going to set target prices for the participants, and the target prices are different than the BPCI program. There is an annual reconciliation that providers are eligible for, and basically it's a simple calculation in that if your average episode cost comes in below the target price, then CMS will pay you that money. And if your average episode cost comes in above the target price, then you are going to owe CMS. There are limits around that we'll talk about in a minute as well. In addition, CMS is allowing and they're incentivizing other people to come to the table. And so hospitals, as owners of the episode, have the ability to share the risk and the reward with collaborators. They can't share more than 50%. Hospitals have to retain 50% of the risk is basically what that looks like. So as I said, hospitals are the primary risk holders, and this is different than BPCI, where either physician groups or hospitals could be the risk holders. CMS was very deliberate in this, in that they said they felt like it was really important that hospitals hold the risk because they felt as though hospitals were better positioned and had more resources available than perhaps a physician group might to manage this risk for a 90-day bundle. And so initially there were 75 MSAs that were selected for the program. In the final rule, that number was reduced to 67. And CMS looked for areas that have a high density of Medicare recipients that did not have high BPCI penetration. They excluded areas that had significantly low or high average costs, or if there were just not significant volumes. And if a hospital is participating in a Model 1, 2, or 4 for BPCI, then they are exempt from the CJR mandate. If they drop out of the BPCI program during the 5-year pilot, then they will become subject, all of those cases will become subject to the CJR mandate. So when you look across the country, it makes a lot of sense where the MSAs were selected. It really does mirror the density of Medicare beneficiaries. There are some areas that it seems were intentionally excluded. When you think about the state of Minnesota doesn't have any participants, and they have organizations like the Mayo Clinic that are very specialized and perhaps high cost. So we anticipate that, based on Patrick Conway's comments, that they will review the results of this program and make the mandate go nationwide sooner rather than later. And we also anticipate the expansion of programs like this beyond total joint replacement. And the most likely candidate there is moving into cardiac procedures as well, so perhaps cabbages or valves. The services that are included in the bundle, they were intentionally very inclusive. The only difference between CJR and the BPCI programs that are currently live is that they now are including hospice claims as well. So all of the Part A and Part B services, and the only other thing that is not included are Part B drugs. So Part B drugs are included, but not Part B drugs. The services that are excluded are the high-cost hemophilia clotting factors, new technology add-on payments, and then there's a list of excluded MSDRGs and ICD diagnosis codes that they deemed unrelated. So those conditions are excluded from the program. When you think about the target pricing, this also varies a bit from BPCI. The initial BPCI pricing was based on 2009 to 2012 historical data and was hospital specific. So the reason I think it's important for folks to think about this is that CMS is intentionally becoming more aggressive in their target pricing methodology. You can see here that the baseline rolls forward with the program, and that also the baseline pricing is no longer just hospital specific, but over the life of the 5-year program, the target pricing, rolls from being on a weighted average to a completely regional average. So initially it's going to be blended between hospital specific and regional averages. And by the time the program is fully mature in years 4 and 5, it's going to be 100% regional pricing. I think it's interesting, I saw some analysis recently that indicated if CMS had launched the program with just regional pricing, that a significant portion of the mandated participants would be in a loss position. So as a result of all of the feedback that went to CMS, they are phasing in the risk, and they are also phasing in the reward. So in year 1, as I said, there's no downside risk. In year 2, it moves to 5%. In year 3, it moves to 10%, and then in years 4 and 5, it's 20%. And as well, they phased in the gain. So in years 1 and 2, you can earn up to 5%. In year 3, it's 10%, and then in years 4 and 5, it's 20%. There are variations in the risk if you are a critical access hospital, for example. So those percentages are a bit lower for the risk and as well the reward. Target pricing is set at the MSDRG level. One other change that CMS put into the program is that there's going to be a target price for MSDRG 469 and for 470. So separate prices for with complications and without complications. And there are also going to be separate target prices put in place for fracture patients for both DRG 469 and 470. The feedback that CMS got was that those patients are really different. They require different services. They're riskier. They have significantly more chance for complications and probably are going to require higher acuity post-acute care. And so CMS listened to that and decided that they would put in separate pricing for that. And that's a big deal. So they also changed their quality score methodology. And this is not all finalized yet either. But it is now going to be a composite quality score. Much of this information is available on the Hospital Compare website so that you can go out and see how you're performing currently. All of the NQF measures, HCAHPS measures, This is stuff that you're already reporting, so this is nothing new. But it is a blended composite score, heavily weighted on complication rate. CMS is really trying to introduce patient satisfaction as an important element of all of these value-based programs, so they've weighted that heavily as well. And then patient-reported outcomes, which is a new element to this, which is why it's only weighted by 10%. But there is a point system that is related to the percentile performance for each of these measures, and you have the ability to earn back part of your discount based on the quality scores. As well, if you don't have high enough quality scores, regardless of how much cost you take out of the system, you're not eligible for gain sharing. So it's really important to focus on your quality and make sure that you're performing well as an organization, so that as you're taking cost out of the system, you're eligible to share that savings. We've gone over some of these elements to talk about some of the differences. So hospital versus physician, BPCI being a voluntary application-based program versus a mandatory model with CJR. Participants had the ability to choose their episode length with BPCI, and CJR, again, took a more aggressive approach and mandated a 90-day episode. We talked about the rolling baseline period and the discounts. The stop losses are different. Stop gains are different. Probably one of the biggest differences in BPCI, there's a quarterly reconciliation process, whereas with CJR, it's going to be an annual reconciliation. So participants that are subject to the mandate won't actually receive a reconciliation for their 2016 participation until summer of 2017. And so there are some complaints that it's really hard to tie the payments to behavior that happened so long ago. So when you think about the collaborators, one of the things that CMS added, there are people coming to the table that as cost is being taken out of the system, they really want to share in those savings, particularly the post-acute providers. So different kinds of gain sharing arrangements are being formed with those folks. And in addition, CMS is allowing gain sharing with device manufacturers. So, for example, as a result of this program being put in place, people have the ability to put a gain sharing arrangement in place with their implant folks, just as one example. CMS is requiring written participant agreements. This is the most audited piece of this program, and we know that from the BPCI program that is in place today. CMS is very interested in everything being formalized and the ability to track all of the money and where it's going, so it's got to be auditable, and it has to be, there have to be written procedures that you can show exactly how the calculations work and where the money is going. So there are two sources of gain sharing funds. There is the retrospective reconciliation payment, and that is a result of savings above or savings below your target price. And then there's a separate gain sharing pool that can be established for internal cost savings. So the things that you think of immediately related to total joint cases are the implant costs, blood utilization, cement, anticoagulation therapy, for example, and how people are standardizing that across their organization and convincing providers to standardize that, follow care protocols. And one important element of this as well is the physicians are actually capped at 50% of the Part B fee schedule, and this is the same restriction that BPCI puts in as well. So if you think about taking care out or taking costs out of the system. When you look at the variation in the cost per day, these are average daily rates for Medicare participants, ranging from $190 for home health to $1,800 a day for acute care hospital. You can see if you can lower your length of stay and discharge to a lower setting of care, you can take significant money out of the system. When you look at the national averages, the average length of stay for DRG 470, which is total joint replacement without complications, discharge average length of stay for skilled nursing is 21 days, which is no surprise because the skilled nursing benefit is 21 days. When you look at best practices across the country, the average length of stay in skilled nursing should be 8 or 9 days. So you can do the math and see what kind of savings that would produce if that's the typical pattern of care within your region. And hospitals are really starting to evaluate their post-acute partners. It's no longer about who has a beautiful marble lobby with a grand piano in the lobby. And so it's becoming a fact-based conversation. And do those post-acute providers have the ability to share data back and forth? And I will tell you that many skilled nursing facilities, for example, that we encounter don't even have electronic medical records. So there's a lot of faxing going back and forth, but organizations are learning how to do this. I'm not saying it's pretty, and I'm not saying it's where it's going to be in the future, but it's a really great start. All of this information is available on the Nursing Home Compare website, that you can pull down all of the data to look at the facility and the services that they offer, look at their quality and outcomes, see if they've received penalties or fines, looking at their patient satisfaction, and really talking to their medical directors and staffing to see, are they strategically aligned with your organization, and are they willing to provide the kind of care that you're interested in your patients having? They recognize that their reality is changing just as hospitals do. And so they're interested in coming to the table and having a very different conversation because they still want those referrals coming into their organization. So when you think about care redesign considerations, it's everything from the preoperative state. Are you doing a joint camp? Are you connecting patients with some kind of care navigator on the front end that's really going to be an advocate for them and help them navigate the care system? Are you doing comorbidity and patient risk assessments prior to surgery? And a huge focus on discharge planning. So how are you handling those care transitions? And many people are putting in some kind of decision tree to look at how they're discharging patients and being very intentional about it. If they have this functional status, if they have this mental status, if they have care at home, for example, then they can be discharged to this setting. And so no longer having that just be the physician's decision to say, well, I send all of my patients to inpatient rehab for 10 days post-acute. And so people are really reconsidering that. And they're also reconsidering it in the fact that the practice patterns that exist regionally sometimes are very different than if you look across the country. And beginning to really be data focused. And so that's what Kurt is going to talk to us about as well. So how are you going to monitor your effectiveness with these programs and talk to your physicians about their performance? It really has to be, again, a fact-based conversation based on the data to highlight the variation in care. So as you're preparing, putting in standardized clinical and care protocols and pathways is an essential element. People ask us all the time and say, just tell us how to do it. Well, it's not a one-size-fits-all answer. Folks like Geisinger will be happy to sell you a care protocol, but it may or may not work within your organization. and all of the assets that you own across the care continuum. And care is local, and there is some variation. So you have to make sure that what you design, your physicians are bought into, and it works for your organization. We know for certain of all the things about these programs, if your physicians haven't drunk the bundle payment Kool-Aid, as we say, and aren't engaged, it doesn't matter if you're the CEO and this is a mandate and you want everyone to be successful. If the physicians are not at the table and wanting to be there, it will not be successful. Looking for cost savings opportunities is really, really important. This is a perfect time for your supply chain folks to shine and say, this is the stuff I've been talking about for years, now let's do something about it. You have to collect your data. You have to look across the care continuum outside of your four walls. And most importantly, these kinds of initiatives are not successful by magic, because I don't think that Harry Potter is within most of your organizations. And if you don't invest in implementation resources, it's the fastest way to fail with this. And people are being wildly successful with BPCI if they implement the programs appropriately and monitor the data and have real conversations with their physicians. And so with that, I'm going to turn it over to Kurt to talk about exactly how you take that data and make it actionable, have those conversations.
Thank you very much, Kimberly. Let me get to my slide here. So when you're looking at your reporting and what you need to measure with your reporting, the best starting point in our mind is to look at the areas where success is going to come and make sure you have the ability to measure those. So success in CJR is going to come most readily and most availably at reduced readmissions, reduced lengths of stay, reduced implant supply or drug costs, reduced OR time, as Kimberly mentioned, altering discharge patterns to what is the most cost-effective care setting for each of those patients, and knowing how you're going to do that. That's another challenge. How are you going to influence that discharge pattern? And then decreasing excess utilization. What analytics should provide for your organization as you go into this is easy to understand insights on these readmissions, on lengths of stay, on the details, so that if you have a question about a variation on a chart, instead of having to run another report and wait and get that information, you have a format or you have a portal or access to the ability to get right down to the Medicare data that is provided. I'm going to talk about that Medicare data here in just a minute. Understanding those discharge sites, who's discharging to those sites, why are they discharging to those sites, why are the variations there, the sources of all variations, and we'll touch on that here in just a second. And then, as I mentioned before, the ability to go from a very high up view to go down to a claim level relatively quickly. That is important, and that's one of those things that you have to look at. Now, before I go into some of the reports, one of the positive sides of this mandate is that our clients have found to be very helpful is the amount of information. You're now going to have access to an incredible breadth of information that you didn't have access to. So as a hospital, you may have had access, well, you certainly had access, and you may have analyzed your own cost data. You may, if you owned physicians and you got their information and managed their costs, you may have had access to some of that, but you certainly didn't likely have access to all of the post-acute care and some of the associated charges with that. So that is something that Medicare is providing. It is a tremendous amount of information that will be provided back to you as a risk taker and participant in this program. And this first chart is really the highest level view. So when we look at the DRG, this happens to be DRG 470, so it's just one of the DRGs. And each one of these columns in this chart is designed to show or to give you a look at, a very high level look at the variations in cost. We start on the left-hand side with your lowest cost. Each one of these is a procedure. You can see the physician's name on there, so you understand who those people were, and it goes all the way up to your highest cost. Across the top, we can see that the green is the anchor admission, the blue is the Part B, that red that you see so much and that Kimberly alluded to earlier is the skilled nursing, the purple is home health care, that orange is outpatient, green DME, blue is your readmission costs, and orange here is your rehab, and then your long-term acute care is in this other shade of purple. So at this level, very quickly, you can see cost per episode and your variation from low cost to high cost. Where we have put this this finger pointing, you would be able to in the portal drill right down at that point by selecting that procedure and go down to more claim level detail. So here is a report that would be designed to show you a little more information, a little more detailed information on these procedures. And so we've gone down on that high cost procedure. We've gone down to an episode detail level to understand what's going on here. And here I've circled that there was a fracture involved in this. So now we have some explanation that might be helpful to you on that variation in cost. Now, it just as easily could not have been a fracture. It could have been because of skilled nursing or something like that. But here you can see that you'll see the claim type over here on the far left, the provider or the physician, the dates of the anchor date begin, the anchor date ending, the DRG, and the diagnosis code right in there, the description of that diagnosis code, and then the amount of that cost that was included in there. Another detail that you can continue down, and so if we clicked on one of those claims, and this was the Franklin Care Center claim, we can get down to really what in essence would be, in this case, a UB detail for a facility. Here we can see other diagnosis codes. We can see patient information on this individual. We can see the charge amount, the beneficiary liability, the total payment amount. So when you're trying to understand those variations on these procedures, it's important to be able to get right down into this level of detail. Same drill down on a provider level. A provider claim level would look like this. So this is the CMS carrier revenue detail. And I want to make sure I mention that there are, I think, 21 different files that data streams that CMS provides as part of this. The greatest source of our business has been organizations that have tried to manage and manipulate that data themselves. That's what our analytics tool does, is it takes that data and puts out easy to understand reporting. So this would be a provider claim drill down information. Here we would switch over, and this is looking at readmissions. So what we can see, and this happens to be for a client that doesn't just have lower joints, so they don't just have 469, 470, but they also have septicemia, and we can see the detail on those readmission costs by DRG. So in this case, what you're looking for is, okay, what happened in terms of readmissions? We're not looking for source of discharge anymore. We're looking for readmissions and what went wrong, what was the reason for those variations. This report is your summary of your physicians, basically by their episode summary. So in this case, we look at Dr. Johnson here, who had 2 cases of 470 during this time period. The average age was 74.5. The average length of stay was 2.5. The average total episode cost was $13,291. You can also see the number of readmissions, the percentage of the total readmissions that individual had, the count of those, the readmission cost associated with those, and the total readmission length of stay and average for that physician as well. Again, one of the savings that you're going to have is trying to understand and looking at those readmissions, and another way to look at those is by physician. Do we have a physician, for instance, that has a higher readmission rate in spite of the fact that they have a lower average age, lower standard average length of stay, and a reasonable cost? We're looking for patterns here in this data, and it's important to be able to pull in reports like this in order to see that type of information. Here is a similar type of report, and the value of this is a client wanted to spend some time digging into their skilled nursing facility utilization. So we developed a series of reports that look by anchor physician at the skilled nursing facility that they're discharging to, and are we seeing issues related to those discharge? So do we have a physician that is discharging consistently to one skilled nursing facility that has a high average cost, so that we can address that? Understanding every aspect of these episodes of care is important, and as you begin to look at this data, we're looking for patterns in here so that we can see this. In this case, what we have is we have a physician that is discharging to 2 different facilities, but the average daily cost is actually fairly significant. Again, Kimberly pointed out that, saving skilled nursing days is going to be a source of savings. But the other thing is finding out the most cost-effective point of discharge, and that may be between facilities as well. So in this case, we have a $177 difference between that average daily cost that sort of jumps out from this report. So what NEPRA, let me explain what NEPRA is. NEPRA is really the thing that would happen on an annual basis, and that is the net payment reconciliation amount under CJR. This is where, excuse me, Medicare decides whether or not, based on the data, you owe Medicare money or Medicare owes you money because you saved money. And one of the reports that's important to understand is, again, by physician, when we adjust the cost based upon a high cost, low cost, your targets and your trims, and I'm not going to get into that during this discussion, but are these physicians contributing to the win or contributing to the loss on this? So a negative number here in this net payment before cap would be a loss. A positive would be a gain. So it'd be a positive experience, and that would be where you could look to get money back from Medicare on this. We then roll it up. This is a quarterly report. As we mentioned, CJR is done on an annual basis. But as long as we have that data, as long as that data is coming in from Medicare, what we're going to do is to provide that updates on that to our clients so they can see as they go along where are they trending. The positive side of an annual is that it's a longer period of time. The negative side is you really aren't forced to look at those trends on a regular basis. What we're trying to develop as part of the reporting is the ability to look at that as it goes along. And in this case, for this quarter, which was second quarter 2015, this organization actually gained $87,940 overall of their admissions. So they've done quite well. Actually, they've done very well on this. We de-identified the data, but they've done very well. So that's how that would be. These are just some of the reports that have been developed. We wanted to give you a taste of what is there. At this point, what I'm going to do is open it up to any questions that you might have. There is a question box on the right-hand side of your screen, if that's how you have that set up, where you can just type in your question. You hit reply. We will see the question, and then we can answer this question. Kimberly, one of the questions I want to start off with is the most common question that we get when talking to organizations who are faced with CGR, and that is, what is the cost of doing nothing to me? So what if I just continue with my current operations right now? Do I really need to do these types of measurements, or can I just continue and just sort of let the chips fall where they may, try to get my money back, and maybe I will, maybe I won't? And so I'll throw that question to you.
So thanks, Kurt. That's a great question. We tell people that they have lost the ability to put their head in the sand and act like this is going away. It doesn't matter what specialty or what area of practice you're in. If you're inpatient, outpatient, post-acute, bundles are coming to you. And so a program like CJR that has 20% risk in years 4 and 5 represents significant dollars to the bottom line. And I don't know any hospital CFO that looks at their most profitable service line has the ability to take a 20% hit on the profitability of that service line. So the risk is really, really significant. When we do analysis for organizations that are subject to the mandate, it's millions and millions of dollars that are at risk as a result of this program. And when you multiply that across the 5 years, it creates a sense of urgency in that this transformation doesn't happen overnight, and you really have to start preparing now and doing the legwork that it takes for successful transformation and making money with these programs instead of facing tremendous losses.
And I guess I'd add that the experience is, and you can comment on this as well, is that there's savings to be had. I mean, there are, especially in these early years when you're looking at this data, there are all sorts of places where there are opportunities to gain from this model.
Well, and just one example of that, we have a client that is in Florida that in their first BPCI reconciliation, they received a $3 million check from CMS. So when I say that there's money to be made, I mean there's significant money to be made.
Yeah. Another question is, if an organization is currently participating in one of the BPCI programs, so maybe it's a physician practice, and their hospital is now subject to this, which takes precedent?
So another great question. BPCI will always take precedence over a CJR initiative. And even within BPCI, physician groups take precedence over hospitals. So the BPCI initiative for joints will take precedence over the CJR initiative.
Okay, very helpful. Well, if we don't have any other questions, then we thank you. As I mentioned before, you will receive a follow-up email, a copy of this presentation from Sally Wood. If you have any questions, our contact information will be on that last page as well. I'll add as a final comment that we are offering an analysis in advance of the CJR based upon 2014 Medicare experience for organizations. It's close to being the same kind of data that you would see for CJR, so that you can look at where are your variations in cost, at least in 2014. The 2015 data is going to come as part of the CJR data. So if you're interested in that, you can contact me as well. With that, Kimberly, I thank you very much for participating, and we will we'll wrap this up.
Kurt, thanks so much for allowing me to participate today. Really enjoyed it.
All right, take care. Bye-bye.